bear with me. Okay, is that coming up?
Yeah.
Yep, great. Okay, so just to flag the next and actually the final webinar in this series that has replaced our face-to-face meeting, that will be in 2 weeks' time, and it's all about involving people internationally in core outcome set development. And same way as you registered for this webinar, you can do that through the COMET website as well. So this week's webinar, it's all about where things are up to in terms of the uptake of core outcome sets, in terms of who is using them, how well they're using them, and what are we predicting about the future. For those of you who aren't familiar with core outcome sets, just to orientate the session, this was a definition coined by COMET back in 2010 when COMET first started, that a core outcome set for trials is an agreed standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. And what COMET has been doing in a publicly available searchable database is to collate published core outcome sets, of which there are now 447, and also registering ongoing sets, 303. So as you can see, there are a lot of core outcome sets that could be used. Are they being used? So this is a diagram that kind of shows, if you like, either a health ecosystem or a health research ecosystem. And if you see that, look at the circle at the top, RCTs, randomized controlled trials, and other research studies. So this is where COMET focused its activity when it was launched in 2010. But now we're seeing references to core outcome sets and references to the COMET database all around this sort of system, whether it's systematic reviews, health technology appraisals, guidelines, quality improvement programs, or routine practice. And so this really forms the basis for today's webinar, with different speakers looking at different parts of this system and where the core outcome sets are being used. But how do we know that people are actually referencing core outcome sets? Well, we keep a note of direct references in organizations' guidelines and manuals, but actually we also ran a short pop-up survey over 4 weeks at the beginning of 2019. The sort of top 5 rows show that people were searching this because they were developing core outcome sets, which was one of the reasons that we developed the database. But you'll also see somewhere near the middle that in terms of people planning a clinical trial, this was about a quarter of the people who were searching during that 4-week period. Just above that, systematic reviewers, that was about 10% of people who were searching. A bit lower down, clinical guideline developers, about 5%. And then in terms of audit, so related to core outcome sets in routine care, about 2%. So it was clear at the start of last year that were a range of different types of professionals and also patients searching the database. So I'd like to, from there, go on to introduce our first speaker, Karen Hughes. So Karen's an MRC PhD student based in Liverpool, and the focus of her PhD is investigating methods to assess and improve the uptake of core outcome sets in clinical trials. And the aims of Karen's study are to bring together studies that have assessed the uptake of a core outcome set across different areas of health, to evaluate methods such as citation analysis as a way of assessing whether core outcome sets are used, and also to look at the impact of whether a funder's recommendation to its applicants helped to raise the profile of core outcome sets. And finally, to explore the barriers and facilitators to using core outcome sets in clinical trials. Karen, thank you.
Okay, thanks, Paula. I'll just share my screen. Okay, can you see those slides okay?
Yeah.
Brilliant, thank you. So hi everyone, I'm Karen Hughes, and as Paula mentioned, I'm a PhD student looking at methods to assess and improve uptake of core outcome sets. And my talk today is about 2 studies from that PhD. So the first is a systematic review looking at core outcome set uptake across different areas of health. And the second study is looking at whether funders can help to improve uptake of core outcome sets. So starting with the systematic review, our aim here was to bring together studies that had assessed uptake of a core outcome set, either in trials or systematic reviews. And to identify those studies, we reviewed the citations that had been received by 337 core outcome set publications. So these publications were all reporting a core outcome set, and we identified those through the COMET systematic reviews. So we reviewed the citations received by those publications because a study assessing uptake of a core outcome set should cite that core outcome set in its own study report. We also set some Scopus alerts to identify any studies of uptake that were published after we had accessed those citations. To select studies for inclusion, we searched the titles of each citing publication for keywords relating to core outcome set and uptake, and then we screened the resulting titles, followed by abstracts and full text articles where relevant. Once we'd identified the studies, we extracted data on the disease, category and name relating to the core outcome set, the period over which uptake was assessed, the number of trials and reviews assessed, and the percentage of those that were measuring the core outcome set. And we also looked for information about potential barriers and facilitators to uptake that were suggested by the studies. So the 337 core outcome set publications received a combined total of 55,693 citations. Once we'd removed duplicates and any articles whose title didn't contain one of our keywords, there were 10,085 titles to screen. Once we'd screened those and abstracts were relevant, there were 345 full text articles to assess, and we identified 19 studies of uptake. So in addition to those, we found another 7 studies through the Scopus alert. So in total, we found 26 studies of uptake. So of those 26 studies, 24 looked at uptake in trials, shown in green, and 2 of those studies looked at uptake in systematic reviews, shown in yellow. So just over half of the studies looked at uptake of a core outcome set in rheumatology. And overall, the core outcome sets assessed came from 5 of 31 disease categories that had at least one core outcome set published at the time of our review. So the studies looked at uptake in 2 different ways. They either looked at the number of trials or reviews that had included the full core outcome set, or they looked at the number of trials and reviews that included each individual outcome from the core set. And this plot is for the studies that looked at uptake of the full core outcome set. So each circle represents a study of uptake, and circles of the same colour represent studies that looked at the same core outcome set. The blue shaded circles represent studies where they were the only study looking at that particular core set. The x-axis shows the period of time that had passed from when the core outcome set was published and uptake was assessed, and the y-axis is the level of uptake. So one core outcome set stood out for having consistently high levels of uptake, shown by the red circles, and that was a core outcome set for rheumatoid arthritis. The green circles represent 2 studies that looked at uptake of a core outcome set for psoriatic arthritis, and the second study found an increase in uptake over time. But the majority of studies found that less than 20% of the trials or reviews that they assessed had included the full core outcome set. So the other thing just to mention about this plot is that the size of the circles are proportional to the number of outcomes that were recommended by the core outcome set, and we didn't find any relationship between number of outcomes and the level of uptake. So for the studies that looked at uptake of individual outcomes recommended by the core outcome set, they found variation in uptake across those outcomes. So just to give some examples, a study looking at uptake of a core outcome set for chronic pain found that some of the outcomes were measured by 90% of trials, whilst others were measured by only 10%. And a study looking at uptake of the chronic gout core outcome set found some of the outcomes were measured by 70, 73, 80% of trials, while the rest were measured by 10% or less, with 3 of the outcomes not measured by any trials. And a study looking at uptake of the fall injury core outcome set found 94% of trials measured one of the outcomes, while the rest were measured by less than 50% of the trials. So some of the studies did suggest potential barriers to uptake, and those included lack of awareness of the core outcome set, lack of validated measures or no consensus on measures for the recommended domains, lack of patient involvement and limited stakeholder involvement in general in the development of the core outcome set, a poor understanding of what a core outcome set is, lack of clarity as to which outcomes were in the final set, patient burden and cost in relation to measuring the outcomes, and a lack of standardized recommendations across regulatory agencies. So this was from a study that had found differences in what the core outcome set was recommending and what regulators were recommending. So we concluded from our review that it is important to review uptake of core outcome sets to identify where uptake is low and to have the opportunity to address that low uptake. So where uptake is low, we suggest considering to revising or updating the core outcome set, which can address lack of patient or other key stakeholder involvement where that hasn't happened during the original development of the core outcome set, by inviting those stakeholders to take part in a revision. Can also address the relevance of outcomes in those cases where some of the outcomes in the core set are not being measured. We also suggest that developers determine the how to measure as well as the what to measure. So this can address that uncertainty around which measures and instruments to use for the recommended domains. And we suggest that developers also consider patient and healthcare professional burden in considering outcomes and measures. So one of the questions that often arises in core outcome set development is how many outcomes should be included in the final set. And from an uptake point of view, we didn't find any relationship between number of outcomes and the level of uptake. So rather than focusing on a particular number, we suggest thinking more about burden in terms of the frequency and length of assessments. And finally, we concluded that further work is needed to understand more about the barriers and facilitators to uptake. So just moving on now to the second study with a focus on facilitating uptake. So one strategy to try to improve uptake of core outcome sets is for trial funders to recommend them to their applicants when they're applying for funding to run their clinical trials. And there are a number of funders who do this. And so we wanted to find out whether that recommendation can have an impact on uptake. So the funder we looked at was NIHR-HTA, being one of the largest funders of clinical trials in the UK. And in January 2012, they included a recommendation in the guidance to applicant document where they recommended that where established core outcome sets exist, they should be included amongst the list of outcomes unless there's good reason to do otherwise. And they direct their applicants to the COMET initiative website where they can search the database to find out whether there is a relevant core outcome set. So to find out if this recommendation had an impact on uptake, we contacted the NIHR Research on Research team, and they gave us access to all 95 applications that were submitted for clinical trial funding between January 2012, when that recommendation was added to the guidance document, up to the end of 2015. So these were all researcher-led applications, and they included those that weren't funded as well as those that were. We carried out a review of those applications where we searched each one for any mention of the COMET database or a core outcome set. And then we carried out a survey of chief investigators to find out more about how they were searching for core outcome sets and what they found. So on reviewing the applications, we found 9 that had mentioned the COMET database and another 9 that had mentioned a core outcome set. So from our review of applications alone, we knew that 18 of the 95 applicants had considered a core outcome set. But then we looked at the results of our survey and we found a further 8 applicants who had searched the COMET database but hadn't mentioned it in their application, and a further 10 who'd searched for a core outcome set using some other method, but again, they hadn't mentioned that in their application. So We knew following the survey results that 36 of the 95 applicants had considered a core outcome set. But it's possible that there may be more. So if an applicant had searched for a core outcome set and hadn't mentioned it in their application and hadn't completed our survey, we wouldn't know about that. Of the 36 applicants that we do know that had considered a core outcome set, 7 of the 36 found and used a core outcome set. 7 found or were aware of a core outcome set that was in development at the time, and they used the findings so far from that to inform their choice of outcomes. And 22 of the 36 applicants didn't find a core outcome set. So we carried out a search of the COMET database to have a look at whether there was a relevant core outcome set for the 95 applications at the time that they were submitted. And we found that of the 95, 24 did have a relevant core outcome set, and we know that 7 of those were used. So we concluded from this study that funders can facilitate uptake of core outcome sets, but there may be further steps that they could take to increase this impact. So for example, if funders could put in place processes to prompt applicants to be explicit about searching for core outcome sets, we would be able to more accurately monitor whether applicants are considering core outcome sets, but it would also act as a reminder. So the guidance documents tend to be quite lengthy documents with lots of information. So this would just be another reminder to applicants to consider and search for a core outcome set. And if the funding board could feed back to applicants where a core outcome set does exist, but it hasn't been included in the application, again, that would raise awareness with the applicants and it would allow them to then consider using that core outcome set. So just to finish with some next steps for uptake work, there are some further assessments planned for those funder recommendations by HRB in Ireland and PCORI in the USA. And we're also planning to do an update of the NIHR HTA applications, looking at those submitted between 2016 and 2019. There are currently interviews ongoing to explore the barriers and facilitators to uptake of core outcome sets by clinical trialists. And we hope to use the findings of those interviews to suggest further strategies to improve uptake of core outcome sets. So I'd just like to finish today by thanking COMET for this opportunity to share some of the findings of our uptake work and thanking you all for listening. Thank you so much.
Thank you, Karen. Okay, so there are a few questions in the chat. I'm going to leave one of them until the end because it's more general. But there's a question from Dorcas. Dorcas, I didn't know if you wanted to open up your microphone and your video just to say hello.
Sure. Hi. Thank you, Karen, for your question. I was wondering, of the 22 in your NIHR study, in that review of the grants, you had 22 who could not find a core outcome set. And I was wondering, of those 22, how often was there actually a core outcome set available, like in the COMET database? Or were those researchers correct that there was no core outcome set available?
So of those 22, we found 4 that we thought may be relevant. So they did search the database, but didn't find the 4 that we thought could be relevant. For the others, we didn't find anything that was relevant.
Okay, thank you.
Okay, that's great. I am going to move things on, and it was a great question, Dorcas, partly because, you know, might be relevant is a useful phrase that I know the next speaker will pick up on. So let me introduce the next speaker. It's Dr. Ian Saldanha from Brown University. Ian is a physician turned epidemiologist with experience in conducting systematic reviews, as well as methodological research for systematic reviews and outcomes research. Ian is an assistant professor and assistant director of the Brown University Evidence-Based Practice Center, which is in the Brown University School of Public Health in Providence, Rhode Island in the US. Thanks, Ian.
Thank you, Paula, and good morning or good afternoon and good evening to everybody here. Thanks again for the opportunity for doing this. So I'd like to try to answer the question about whether systematic reviewers are using outcomes in core outcome sets. So I come at this question from my background in doing systematic reviews and strong interest in core outcome set work, but doing systematic reviews mainly under the auspices of 2 organizations. That's Cochrane and the Agency for Healthcare Research and Quality's Evidence-Based Practice Center program in the US. So I'm going to start by telling you my main messages. I'm going to start by telling you what I think is where we are in this field. The news is what I call as decent to good. There seems to be, it seems to be the case that systematic reviewers are recognizing the importance of core outcome sets, and about 60%, or a little more than 60% of outcomes that are in core outcome sets are being incorporated or considered in systematic reviews. But as is the case in many things, more work remains to be done on this front in terms of thinking about the scope of reviews and core outcome sets, and sort of promoting the involvement of systematic reviews to an even greater extent than is happening at the moment in the development of core outcome sets. Those are my main messages, but I'll come back to them later. So just to remind everybody, if it's been a while, or for those who are new to the concept of a systematic review, we go through a set of steps to find all the evidence that addresses a given research question. And this evidence might come from primary studies like clinical trials, but we tend to also often look at other study designs. So we start by framing the topic, we then go search for the evidence, we screen for studies, we extract data, or we abstract data out of the studies, and we analyze or synthesize what the data that we have, and then we report our findings. In beginning this process, we start by framing the question of a systematic review in terms of who are we studying, the populations, the interventions and the comparisons, and the outcomes of interest. This should look very familiar for those who have done clinical trials, who've read about clinical trials. We use a framework that lays out these four aspects predominantly. And as you can see here, predominantly here is the concept of outcomes, which is why we think a lot about them in systematic reviews as well. So where was the field a few years ago? I just wanted to start by a few years ago. This is from about 4 years ago now, work where we sort of looked at the overlap in outcomes between clinical trials and systematic reviews. Are they interested in similar things? So what you're looking at here is 4 plots. Each of these is within the field of ophthalmology, where we looked at Cochrane reviews in ophthalmology and the studies that they included. To what extent are those outcomes overlapping? The plot here for each of these is a plot of the percentage of trials that are reporting the outcome versus the percentage of reviews that are reporting the outcome. And these are trials and reviews on the same topic. So we plotted the percentage against each other. In an ideal world, you'd see a lot of outcomes up top over there in the top right corner, which is there's a high percentage of outcomes that are overlapping. But if you squint your eyes a little bit here, for each of these different disease areas in ophthalmology, you see a large proportion of the outcomes concentrated in the bottom left quadrant. We did similar work in HIV/AIDS, and we see a similar concentration of outcomes in the low percentage of overlap, if you would. So the news a few years ago wasn't as good. So we did more recent work where we started to look at, does the systematic review world really recognize the importance of core outcome sets? This was work that was published earlier this year in collaboration with Paula and Sarah and others on this call as well. So I wanted to summarize to a certain extent the response to that question of does the systematic review world recognize the importance? And the answer is sort of yes to a certain extent. So what we did was we looked at the first 100 Cochrane systematic reviews of 2019. We chose those, we looked at them, and 40% of them identified a problem of outcome inconsistency. So 4 in 10 reviews recognized that there was a problem. They mentioned it in the discussion, they mentioned it in the results. And 7% of them though, only 7% at the time, I mean, not that long ago, 7%, you might look at it and say at least 7% are using core outcome sets in relation to outcome choice, but 93% did not explicitly do it. And when we looked into the COMET database to see whether a core outcome set existed for that same topic, only about 29% of the remaining, we found a relevant core outcome set, but 29% is not a small percentage. So potentially these 29% of reviews, or 29% of those that didn't, could have potentially used a core outcome set development, core outcome set that had been developed in their outcome choice. what we also did was surveyed Cochrane editors. So the Cochrane organization or Cochrane systematic reviews are organized into various topic areas predominantly. Each has a set of editors, and there are about 50 of these Cochrane review groups, each having editors. We surveyed 32 of these 50 Cochrane editors. We tried to reach all, but these are the ones that responded. 84% were of the opinion that core outcome sets would be advantageous for a systematic review. So there's quite a strong recognition, at least from the editorial end. But the challenges they identified were persuading authors, getting authors to try and consider outcomes that are in a core outcome set, and potentially in addition to outcomes that they were interested in themselves, but also consider outcomes in a core outcome set. But one of the major challenges was scope, thinking about, does a core outcome set apply to my topic of interest in the systematic review? So we more recently started thinking about this notion of scope and a little more than we had previously. And thinking about scope is rather complicated. There's two levels that you can conceptualize scope at, really. Does the systematic review topic area match the core outcome set? But the population intervention comparisons outcomes framework that I talked about already is for defining each question in a systematic review. A systematic review can have multiple questions. So it could be that the core outcome set applies to the entire review if there's one question, if it does. Or if there are multiple questions, it might apply to 1 out of 5 questions or 2 out of 5 questions, and so on and so forth. So thinking about scope, the population interventions and comparisons is the first thing we start to think about when we're thinking about scope. Does the population of interest match? Do the interventions and comparisons match? So thinking a little more deeply about that, we started to put together a framework where we said, okay, if we think about the population, it could be that in terms of breadth, the core outcome set is a narrower, has a narrower population of focus. Or it could be an exact match, which is great. Or it could be that the core outcome set is broader. Or it could be that the core outcome and the core outcome set and the review are addressing different subgroups. For example, the review is focused on children, whereas the core outcome set is focused on adults, or vice versa. Then thinking about intervention. In terms of the intervention, similarly, the core outcome set could be narrower, it could be an exact match, or broader. But there could be a different intervention. And different intervention doesn't mean, in this case, completely different intervention. It's that it's close enough, but somewhat different. So if we conceptualize these sort of scenarios, we can go ahead and start to put like alphabets in there to denote the various situations. In our discussions, this aspect of different subgroup of the population is one we thought of as particularly needing clinical decision-making or clinical consideration. I mean, all of these generally do, but particularly the ones at the bottom here, where the core outcome set and the systematic review are sort of addressing different subgroups of the population. And does a core outcome set develop for children, apply to adults, or vice versa, is often a clinical consideration. So what we then did was, we said, in these various situations that I just explained, would we sort of hazard a guess as to how likely is the core outcome set going to be relevant? So we started to do this, and I don't have time to get into the depths of the discussions that went in here and trying to figure out in which cases would the core outcome set be very likely to be relevant, may be relevant, or unlikely to be relevant. But for now, let it suffice to say that we ended up with the four scenarios in the center, the F, G, J, and K, were situations where we said the very core outcome set is very likely to be relevant. But situations around it in orange are situations in which the core outcome set may be relevant, but when it's a different intervention, even if it's somewhat related, it's probably unlikely to be relevant. And as I mentioned, I mean, you might end up with slightly different colorings in this sort of a figure, but this is a framework for sort of to think about the scope of the core outcome set and the review. So we said, okay, that's a framework. Let's now look at an empirical assessment of this issue. So what we did was, like what we had done similar work for the Cochrane reviews earlier, we said, let's do a similar piece of work for AHRQ evidence-based practice center systematic reviews. the AHRQ is a government entity in the US that funds evidence-based practice centers in the US and Canada to do systematic reviews, often for third-party stakeholders. So I work at one of these evidence-based practice centers in the US at Brown, as Paula said. So what we did was we looked at, for the last 3 years, or I guess 2.5 years, 2018, 2019, 2020, we looked at all the systematic reviews that the program has put out across all the centers. We found a relevant core outcome set for more than half of them. So this percentage is now higher. It was about 30% for those Cochrane reviews at the time. It looks a little higher. It's 54% for these reviews. These matched to 62 different core outcome sets. The reason these ended up with 80 pairs. And the reason the numbers don't exactly line up is because a review can match to multiple core outcome sets that might be relevant, and vice versa. So we had 80 pairs to go on. We said, okay, let's now populate that framework that I showed you and see how often we had situations of each of those in those 80 matches. So the denominator here is 80. If you add up the yellow cells, you see that there are 51 pairs of systematic reviews and core outcome sets, where the core outcome sets is very likely to be relevant. There were 17 where it may be relevant, so it obviously requires decision making. And also, there were 12 that fell into that category of a related but different intervention, where we said, okay, 12 out of the 80, it may be a bridge too far to say that these 12 pairs represent relevant core outcome sets. So we sort of dropped them in subsequent analyses. So we focused on the 68 pairs of reviews and outcomes where there was a match. So where we said, okay, we would be comfortable saying either the core outcome set, let me go back to the exact words, is very likely to be relevant or may be relevant. So those were 68. So now how do those outcomes compare? So I talked a little bit about how the populations and interventions compared. How did the outcomes compare? So what you're looking at here is a box plot from the perspective of the outcomes that were in the review. So looking at the systematic review outcomes, the bluish purple color box on the left is matches between systematic reviews and core outcome set outcomes that were either specific, meaning that there was pretty much an exact match in the outcomes, or there were general matches, meaning there were related outcomes that we could say one is narrower than the other one, or vice versa, but they're close enough but not exactly the same. And then of course we have the non-matching outcomes on the right. So the 40% median is the way I would interpret that is that 40% of outcomes in systematic reviews in this set of AHRQ EPC systematic reviews are specific or general matches to the corresponding core outcome set, whereas 60% were complete non-matches. So that's the interpretation of this box plot. When we looked at the outcomes from the perspective of the core outcome sets, so remember the core outcome sets and the reviews matched, but they have different numbers of outcomes in them. So it depends on which you have as the denominator. So if you had the core outcome set outcomes as the denominator, more than 60%, so 62% exactly, were being taken up by systematic review outcomes, or core outcome in systematic reviews in terms of being general or specific matches, whereas 38% were not being taken up by systematic reviews. So that's the 62% that I started with on my main messages. What about number of outcomes? So Karen also talked about this concept of does having more outcomes in a core outcome set, or does having more outcomes from my perspective in a systematic review make a difference in terms of the overlap? So if we start with, again, on the left here, I'm going to have another figure on the right. If we focus on the outcomes in the reviews, in the systematic reviews, you see that having more outcomes in a research question in a review leads to a lower overlap in a lower percent match, if you would, between the outcomes in the review and the outcomes in the core outcome set. So the green here are those specific matches, meaning that they're exact matches, and the blue are both specific as well as general matches. The interpretation here suggests that the more outcomes you include in a review, the more potential there is for adding additional outcomes that are not in the core outcome sets, and sort of that match goes down as you increase the number of outcomes in a review. From a core outcome set perspective, this conclusion is sort of similar to Sarah's, is that having more outcomes in a core outcome set doesn't necessarily mean that those outcomes are going to be taken up by reviews. And that points to me to a sort of interpretation that sort of might be in the line of this might be a hint towards systematic reviewers in being interested potentially in certain additional outcomes that are not being incorporated into, that are not in core outcome sets. And that is an important message, I think, in terms of thinking about what are systematic reviewers interested in. And I'll get back to this notion a little later. All right, so, well, not too much later. So some closing thoughts from some of this work in terms of populations and interventions, and this is both from the Cochrane piece of work that I talked about as well as the AHRQ piece of work. The range in terms of where the populations of and interventions of reviews have relevant core outcome sets in terms of thinking about the topic and the scope is about 35 to 53% is probably where we are now, 34 to 53%, probably in the higher end of that range based on more recent work that I showed. In terms of the outcomes themselves, 40% of systematic review outcomes that are being used in systematic reviews are in core outcome sets. And a higher percentage of the core outcome set outcomes are making it into the reviews, which is perhaps good news from the perspective of the ecosystem for this group, for the COMET group. Opportunities abound though. There's no, if you think about it, there's no obvious reason why a core outcome set outcome or a set of outcomes in a core outcome set should not be relevant for a systematic review. If you think of the ecosystem, that's part of the purpose of why these outcomes, why these core outcome sets are being developed, is to facilitate a sort of common blueprint, if you would, in terms of a list of outcomes that everyone potentially should be interested in. And therefore, one of the things we suggest is that systematic reviewers should consider core outcome sets as a starting point when deciding on outcomes for the systematic review, and potentially even focus on the core outcome sets when trying to decide on the summary, or trying to decide on which key outcomes will be highlighted in the summary of findings tables. The summary of findings tables, sort of a quick description of them is that they are sort of tables that that, as they say, they summarize the key findings of the review. They are the main outcomes on which, the outcomes that are in the table are the main outcomes on which the decisions about, or the conclusions of the review are based on. So we suggest that these might be good, core outcome set outcomes might be a good starting point, both for including of outcomes in the review as well as the ones that might be focused on in summary of findings tables. But challenges remain. Awareness is not 100%. Awareness, no, not even close, but it can be better. We think that approaches that consider implementation science, because after all, we're trying to implement core outcome sets in practice. We're trying to, in some ways, change behavior about outcomes that are chosen for the review. So there's science behind approaches that could be developed and used for promoting this. But I think also to sort of increase buy-in from the beginning, I think that, and we've been saying this for a while, more systematic reviewers should be involved with core outcome set development. Of course, there are initiatives already underway to promote this, which is fantastic across various topic areas. But future work should also evaluate why there are some differences in outcomes in systematic reviews and in core outcome sets. And so those are some of the challenges that remain, but I'd like to end on a bit of a positive though, in that there is I hope I've conveyed to you that there is a fair amount of good news in where the field, where we are in terms of uptake at the moment. one of the ways in which that's sort of highlighted is in this piece of text from the Cochrane handbook. So this is a handbook for those conducting systematic reviews within the Cochrane collaboration, but these methods are widely used across various organizations and around the world. So there's language in there that actually explicitly states that where available, established sets of core outcomes should be used. And of course, patient-reported outcomes should be included where possible. But there is an emphasis on the consideration of the consideration of core outcomes, and almost by default that implies, and I think there's other pieces of the handbook where they talk about searching the COMET database and such. So I'll come back and end on my main messages, which is the news is sort of decent to good. Systematic reviewers seem to be increasingly recognizing the importance of core outcome sets. At least 60%, about 62% is of the outcomes that are in core outcome sets, at least in the sample that we have looked at, are being used in systematic reviews. But to promote future work, to promote further uptake, future work remains to be done in terms of thinking more deeply about this matching of scope between the core outcome sets and the systematic reviews. And of course, as I mentioned, promoting the involvement of more systematic reviewers in the development of core outcome sets, so that potentially when those core outcome sets are developed, those would be incorporated into systematic reviews as well. So thanks to COMET for inviting me, and all my collaborators, of course, for your ideas and contributions, and all of you right now for your attention, and for those, I guess, listening to the webinar later. Thanks.
Thanks, Ian. Thanks. I'm going to invite one quick question here, or one probably isn't a quick question, but hopefully there might be a quick answer, and we can come back to it at the end. So Alex Corral, sorry if I'm mispronouncing your surname. Do you want to open your mic, Alex?
Hello, thank you so much. I'm just wondering, so I've done a little bit of work examining core outcome set uptake, and I'm wondering how you went about assessing the scope of the population, but also about the scope of the intervention. So more specifically, I'm wondering, did you consider more nuanced differences in the population originally promoted in the core outcome set and the systematic review? Because the example you gave was quite, I think, an obvious difference between children and adults. But in my work, I look a little bit more about older people and whether or not there are differences perhaps between older people with cognitive impairment versus not.
Yeah, so I think that's a great question. So one of the things we did, I mean, I talked about the framework between thinking about breadth. I think breadth is a big aspect of it, but there were quite a few examples that fell into that aspect of slightly different population. There were things about setting, which also came in quite a bit, but we sort of roped in the aspect of setting within the consideration of the population, so such as hospitalized versus non-hospitalized patients, or in a particular set of developing countries versus more developed countries. So those are a set of considerations that we've sort of put into the sort of that bottom row of that table, if you would, in the different subgroup of the population. But there were the framework is not sort of designed to sort of get at every situation. There were some situations where we sort of we said it in an ideal world, if this was being done for a given core outcome set for a given systematic review, there would be quite a conversation that would need to happen between the clinical experts on that core outcome set, I mean, on that systematic review, to say, does this population really match to the population that we've laid out in our review? So I think that sort of that asterisk that we put for that lowest scenario, although we put it only for that lowest scenario in terms of population subgroups, I think that asterisk generally applies throughout. There's always these set of considerations that has to be made that must consider the perspective of clinicians. Yeah.
Okay, sorry to cut a little short perhaps. We'll try and come back to this maybe at the end. Thanks very much, Ian. Thank you. Okay, so back to me. Hopefully you can see the screen. You see my, yeah. Right, okay. Okay, so I just like to mention, so on the COMET website, we are trying to acknowledge organisations who endorse the use of core outcome sets in their work, whether it's trialists, systematic reviewers, guideline groups, etc. So you can find lists of organisations. And as you've just heard from both Karen and Ian, we're now seeing recommendations in funders' guidance and in the Cochrane Handbook. And as we move around this sort of ecosystem, we're also seeing recommendations to consider the use of core outcome sets in health technology appraisals, in clinical guideline development groups, and actually in the UK, also in healthcare quality improvement programs. I'd like to just spend five minutes finishing in the top left-hand part of this diagram, and that's around core outcome sets for routine care. So when we've looked at our review, we've been systematic review, we systematically search for core outcome sets for research, but in and amongst those, we find core outcome sets that aim to develop one set that's relevant to both research and practice. And we've seen a real shift recently. So up until the end of 2019, 12% of all the core outcome sets for research were actually being designed with the aim of being relevant to both research and practice. If you look at the ongoing core outcome sets, actually over half of them aim to do that. So there's been a real shift in people's thinking about whether or not they should be developing separate core outcome sets for research and practice, or maybe a single one. But a note of caution. So when you look at those core outcome sets for research and practice, those of you that have been involved in the development of a core outcome set will know that the starting point is to look at what's already measured, to kind of develop a candidate list, to then add to that list and then subject it to a consensus process. If you look at the core outcome sets for research and practice, you might imagine that not only are they looking at the research literature, but because you're talking about practice, they might also be looking at the electronic health record, clinical notes, databases and registries. In fact, only 10% of those core outcome sets have gone to those sources from the start. So one might hope that when you look at core outcome sets for practice alone, and bear in mind that COMET at the moment comes across these sorts of core outcome sets sort of opportunistically rather than systematically. However, of the ones that we've found, it's a little better, but it's still only a third of those that have looked at what's actually measured in practice. They tend to follow the same methods as we do for research by looking at the research literature. So why does this matter? Okay, well, work done here by a PhD student in Liverpool, looking at observing clinical consultations for patients with inflammatory bowel disease, looking at what data are discussed, what data are recorded in the electronic health systems. She's found that, well, measuring outcomes in routine care or indeed in the record has challenges. They might be practical challenges. For example, one person reported that they were having to enter the same data in 3 different places, and that was frustrating. They also said they didn't know whether, recording data was as useful as looking at the patient, listening to their symptoms and seeing how much impact the symptoms are having on them. But there was also benefits to measuring outcomes in routine care that was noted. Benefits such as, well, while it was seen as a bit of a nightmare, when all of these regulatory approvals came in for the use of these high-cost drugs, then it's been a real benefit to see the way how we assess our patients in the clinical setting. And they also found that asking patients to measure their symptoms using a particular instrument, that they found that it was helpful because it's safe to put those patients out in the community, provided they're self-reporting those symptoms. So challenges and benefits. And if we really want to extend and embed core outcome sets into routine care, which will have benefits for research, then we really need to address the collection of patient-reported outcome measures. So this is quite a complicated slide, but what it does is show across those 447 core outcome sets that we currently know are published, we've looked at all of the core outcomes within them and classified them according to a taxonomy, looking at these across the domains. And if you look at we split the results into whether or not the core outcome set included patients or not in the development of the core outcome set. And if you look at the numbers in red, if you go to the third row down, which is the life impact domain, you will see that without patients being involved, 63% of the core outcome sets include something in that area, whereas when you include patients, that goes up to 86%. And there are patient-reported outcome measures elsewhere in the physiological clinical domain, such as pain. So patient-reported outcomes are core to almost all core outcome sets. So what we decided to do was then to say, okay, let's have a look as a case study at how core outcomes track or indeed translate through that system diagram. So the first column here is a core outcome set for type 2 diabetes. The second column is a set independently developed for routine care. And as you go through the diagram, you've also got outcomes that are recommended in the EMA and FDA regulatory guidelines, outcomes in the NICE clinical guideline, which informs the NICE quality standards in the UK and the quality indicators. And finally, it shows the outcomes that are measured in CPRD, Clinical Practice Research Data Link, which is effectively NHS records from people seen in primary care. And I'd like to draw your attention to the second from the bottom row, activities of daily living. Okay, because I thought when I first saw this, I thought that's pretty good. You know, there's quite a lot of ticks running all the way through from a core outcome set for research right through to our very own NHS database, CPRD. But interestingly, activities of daily living is a challenge. So whilst it's in the research core outcome set, it's not in the routine data set, in the routine core outcome set. It is actually in our NHS records, but it's in narrative text. Okay, so I'm not trying to minimize the challenge of linking in coded patient-reported outcome measures so that we can then use them for practice and for research. So just to quickly finish off, because this is a webinar about core outcome set uptake, one might imagine that in a pandemic, when there is such a need to collaborate and join forces over research, that if a core outcome set existed, that everybody would who knew about it would look to use it. Well, early on in the pandemic, there were 4 core outcome sets that were started. Actually, they overlapped in terms of what we refer to as a meta-core outcome set. If you look at treatment of hospitalized patients with COVID-19, there were 2 domains in that meta-core outcome set, mortality and respiratory support. So you'll all know how much research is going on in the treatment of COVID-19 patients, but were they using core outcome sets? So this nice paper that's just been reported recently looked at 415 trials up until 5th of May 2020. And in the hospital-based studies, which were the majority of those 415, yes, mortality was measured, not in all studies as either a primary or secondary, but overall for the 2 domains, about half measured both of them. Now that was May, and unfortunately this is still with us and we're in November, and that update of the assessment is ongoing. We know that several influential funders, big funders, were referring to the meta core outcome set. So we hope to see the impact to see whether that percentage has increased. So in summary, hopefully the webinar has shown you that, you know, there are many different organizations who have an important role to play in improving the uptake of well-developed core outcome sets. From my particular talk, I think it's really important to establish whether and where a common core outcome set for research and practice is possible to achieve. We don't have enough experience yet about implementation in research, let alone implementation in research and practice. So this is very much a research area going forward. Thank you. So let me stop sharing and I will come back to the questions in the chat. I'm going to jump back to one, which I'm going to ask Karen to respond to first. And that was from Brona. Were you able to determine the average timeline between publication of a set and its appearance in trials or systematic reviews? So Karen and or Ian, do you want to comment?
So from our systematic review, we didn't actually look at that, but that said, we can look at that. The data are there to find out. Well, certainly we can look at the time difference from when the core outcome set was published and when it was first cited. That would be really interesting to look at, actually, so we could do that. In terms of uptake studies, the one that had the kind of shortest time from when the core outcome set was published to when they assessed uptake was 3 years, and the core outcome set was being used at that time. I think for that study it was around about 25% of the trials that they assessed were using the core outcome set, so that during that 3 year period. But yeah, I think it would be interesting for us to look at that and see when it does start to get cited.
I'm very sorry, Brona. I was very rude and didn't ask you to unmic and ask your own questions. So what I'm going to do now, I realise there's some questions going on in and comments and replies in the chat about protocols for systematic reviews. Do you want to open up your mic, Brona, and either ask and also answer that question based on the chat?
Well, thanks very much, Karen, for that answer, because it is interesting. When do I mean, I had developed a core outcome set, but I'm very interested to find out when did the first people start to use it, or actually, you know, and I suppose you find that in clinical trials, but it's very hard to find, you know, just to track your own systematic review before it then maybe comes out in publication or somebody mentions it. But so that was interesting. Yes, in relation to uptake of core outcome sets in systematic reviews, and I mean, I've had this conversation as well with our editorial group in Cochrane, and that's the critical care, acute care team. And it's, I've always said, why do we have, when it comes to types of outcome measures, why do we always have primary outcomes and secondary outcomes? Because that's what you do in a trial. You usually choose a primary to power your study. But why do we need that in a systematic review, and particularly now with more the greater trend towards using core outcome sets? I sort of feel that it shouldn't be divided between primary and secondary, but should be what are the important outcomes. And I think in that way it's easier than if there is a core outcome set to sort of bring that in and say, these are the important outcomes that we want to include, and then reference that core outcome set. Because I feel it's certainly in some of the reviews that I have been editing, it's not, it doesn't come across that some of the authors have even said that they've looked for a core outcome set, and I think we should be promoting that a little bit more within Cochrane.
Yeah, thank you, Brona. I completely agree with pretty much everything you said. The notion of a primary and secondary outcome means so much in a clinical trial, and it doesn't really necessarily mean anything in a systematic review. I think the Cochrane reviews, at least as far as I can tell, initially started out by doing this sort of differentiation because because of familiarity with the concept. And as the movement grew towards using, I think effectively what are 7 outcomes in summary of findings tables, I think the relevance of these primary versus secondary outcomes isn't as helpful.
Yes.
I think the language can be a little confusing, but I think it's a remnant of where it started out, and I'm not sure whether there are plans to just get rid of that terminology. But there is definitely, as the work that I've talked about and others have shown, is that there is a recognition that some outcomes should be prioritized over others, and that gets reflected in summary of findings tables. And as you're saying, the more that we can push core outcomes into those summary of findings tables, the better.
Okay, thank you very much, Ian.
I was literally, I was literally about to invite Peter Tugwell, who is a Cochrane editor, and to come in on that last sort of point, but he's just messaged to say he's had to jump off. What I do want to do though, and I can see that Martin de Wit is here from OMERACT as well, and so there's there's a few people from OMERACT actually. So what a couple of the questions have been, and it does relate to uptake, have been around when you've determined what is important to measure, what's core, and then you're trying to work out how to measure it. And sometimes, there may either be no measurement instrument, maybe for a patient-reported outcome measure that's core, or there may be a measurement instrument, but it's pretty rubbish on some of the relevant psychometric properties. What do you do? So I'm going to see if Martin de Wit actually wants to come in here and talk about the experience in OMERACT, perhaps around the fatigue. Martin, are you okay to be put on the spot a bit?
Yeah, thank you. I think this was very interesting, specifically also one of your final slides where you compared the number of outcomes, specifically also for life impact, where you showed if patients were involved, you see more life impact measures involved and included. So that was interesting. Regarding your question, I think that's interesting, and I don't have the full answer, but the one that I can imagine is that it's important that patients, of course, not only have to be involved in the development of core outcome sets, but also in the update process and regular update of core outcome sets, just to look at the patient's relevant domains still included, and are there new data also specifically on instruments that might suggest that new instruments or instruments that have been better assessed should be added to the core set because they, for instance, have a better match with the patient perspective than existing instruments. And of course, we know that although some instruments from the past are patient-reported outcomes, and it's good that they are included, but they are not always any more fit for purpose. And I think patients can be very helpful in assessing the domain match and sometimes also this feasibility of instruments. I don't know whether that's an answer to your question.
It is very interesting observations, Martin. Thank you. I am conscious of time, and people are starting to drop off. Okay, yep, Ian's going to do some, we will be putting some things in the chat. Can I come to, so there was one question in the chat about why the number of disease areas where there was uptake seemed to be so low, a number of small areas. So in Karen's systematic review, they were the only studies we found, published studies, that had looked at the assessment of uptake of core outcome sets. And this is very much something that COMET would like to change, because people are really understanding the need for core outcome sets. People are developing core outcome sets. There's now 300 that are ongoing, and if we don't look at uptake and understand barriers and facilitators, then we are contributing to research waste that we're trying to decrease. So I don't know whether Karen or Ian, you've got any comments on how we might either enthuse people and who we should be enthusing to look at the uptake of core outcome sets. Should it be the core outcome set developers themselves? Should it be others? Do you have any thoughts?
So I would just say, I think part of core outcome set development does involve this assessment of uptake. It's really difficult because once a core outcome set's been developed, it's not to say that those developers are going to be available to continue on and do the uptake and do revisions. But I think it's really important to assess that uptake so that revisions can be made and updates where appropriate with regards to measures and as technologies move on and so on and so forth. So I would say, yeah, core outcome set developers, but I think it depends on, you know, the logistics, I guess, of doing that.
Ian, did you want to?
Sure. One analogy sort of comes to mind in terms of when we think of primary research and everyone who does research, we spend so much time on doing the research. We don't spend as much time as we probably should on getting the research out there and disseminating it. And I think that applies to core outcome sets as well. We do excellent work on core outcome sets. We write papers about it. We don't necessarily go that extra mile on, or at least towards engaging with those who might be adopting it. And that's where I try to make a point about trying to use principles of implementation science and to try and boost the uptake and take it a step further. And unfortunately, at least in primary research, it's happened that there isn't necessarily the same set of people who are doing the research who try and get it out there. And that maybe part of that might happen in the core outcome set or needs to happen in core outcome sets as well. But I'm sure there's a lot more to be said on that front. So.
Yeah. And in fact, Gillian Short has put a great idea that people developing the core outcome set should do more on the dissemination and contact lead authors of key systematic reviews. I agree with your suggestion, Gillian. I think that'd be brilliant. But to go further than that, actually, they may want to also contact funders in their area. Maybe not the big funders like NIHR, HRB, PCORI, who are already recommending consideration of core outcome sets. But there are disease charities that specifically work in an area. We're really keen, not just for sort of peer-to-peer dissemination, but active dissemination by core outcome set developers, maybe to the journals that are, in that. I mean, the Crown Initiative looked at promoting core outcome sets for obstetrics and gynecology through over 70 journals. It could be that a core outcome set development group can identify the avenues early on. And if you can identify them early on, then involve the people in that impact pathway early on as well. Okay, so I'm going to check with Sarah. I think we can save the chat and then make some responses via email, because although I could spend all day talking about this, I don't think everybody would want to be here all day. So I'd just like to thank Karen and Ian. Great talks. Thank you all for being a great audience. This will be recorded, has been recorded, and it'll be up on the website soon, in the next few days. Something like that, Sarah, is that true?
Hopefully tomorrow.
Okay, and final webinar 2 weeks today, an hour earlier than this started, but hope to see you then. Thanks very much and enjoy the rest of your day, or a good night's sleep for some people. Goodbye.